side effects. How many of us can say that about the drugs that we take, that they don't have side effects if done correctly? Okay. So every dose is 100% effective. What drug does that? Even small ones. Okay. It doesn't have to be marathon running. It can be small doses that we're going to talk about. And as I said, it's free. Okay. It's free for the most part. You don't need mega doses. So the recommendation, both for Parkinson's and in general, is only 150 minutes a week. That's 2.5 hours in a week. It doesn't have to be done in 30-minute stints, but 30 minutes times 5 days gives you 150 minutes. And you should do twice weekly muscle strengthening, some of the body weight movements that you could find in yoga, Tai Chi, or Pilates. Now, unlike some of our drugs, exercise, more is better. And pushing yourself ramps up the benefits. So, as the intensity of the exercise goes up, you need less of it. So, the intensity should be determined whether you can speak or sing while you're doing it. Okay? So, walking to the mailbox and back isn't intense. Okay? That's not exercise. Opening the door for the dog. Not exercise. We need some form of exercise that has some intensity to it. And short bursts of intense exercise has been shown to be just as effective as longer duration. So if you do 15 seconds intense, and then 15 seconds slow on your walk, that is just as useful as trying to go at a certain pace for 20 minutes or above. So short intense can be just as good as a longer workout. It's not appropriate for everyone, but that's what the therapists and the people on this panel would be able to help you determine what's best for you. All right. So active older people resemble much younger people physiologically who exercise. So it's up to us how we partially age. And a study way back when in the 60s showed that 20-year-olds who sat in bed for 3 weeks had the same physiological parameters, so heart rate, certain blood studies, of people twice their age after 3 weeks of bed rest. So it is something that affects all ages, whether you're in your 20s, 40s, 60s, 80s, or beyond. Exercise alters cell function and gene expression. And a study looking at 12 weeks of exercise that had intensity to it showed that there were changes in the expression of proteins from genes, both in the young and in the older individual. It was more in the older individual, so the potential benefits at the cell level was even higher in the older individuals who did this study. And this study suggested that increased levels of these molecules in muscles may slow the aging process, and as we talk about Parkinson's disease, may affect progression in that disorder as well. Exercise also affects the brain, and there are clear benefits that apply to the brain. First of all, those people who exercise have lower levels of anxiety and depression. And one study showed that 45 minutes of exercise 3 times a week was equivalent to taking the medicine Zoloft or sertraline. All right, so again, a way to lower your pill burden if you suffer from anxiety and depression, because exercise releases serotonin and endorphins, which affect mood. Also been associated with less memory loss, and is the most effective known way to prevent Alzheimer's disease. And we're getting more data in regards to Parkinson's disease, but that is not completely clear. It's known that exercise improves blood flow, causes new blood vessels to develop, and this is primarily through the expression of a factor called brain-derived neurotrophic, which means promoting growth, that increases in the brain when exercise occurs. We're not only wanting you to exercise your body, but we also want you to exercise your mind. And it's not the focus of today's seminar, but it's important to use your thinking functions as well as your muscle functions. And so Dr. Garcia may comment more about these kinds of things. If you don't ask the question of him, I will. But that's something that I also want you to consider when you talk about exercise. Okay, so that's the next segment. So now we're ready for questions. If the panel wants to state anything, please feel free to comment on it.
I think for a lot of our persons with Parkinson's, with regard to Dr. Appert's comments on intensity, we emphasize that in therapy with our patients. But I want, just so people don't get deterred by that or maybe cause a level of anxiety when you think about intensity, when some of you have balance issues and the bradykinesia can feel overwhelming and you might use an assistive device. Don't think that you still can't be intense with your exercise. It's sort of individualized, in my opinion. What I tell my patients is, yes, we want you to exercise intensely, but it's also a kind of a hyper focus on what you're doing at the time. I tell my patients, I'd rather you go take a 5 to 7 minute walk with really good erect posture, focusing on your breathing, your stride, rather than just lollygag down to the mailbox. That's the kind of thing that's, and I mean, that's better than sitting on the couch, I'll grant that, but it's really a focus on the exercise you're doing. I think that's why, and maybe you can sort of comment on this, I think that's why yoga is so beneficial, because it requires you to focus as you exercise. Whereas a lot of people sit on their recumbent bike or get on elliptical and just watch TV. And they're not paying attention to their posture, their head posture, very important in Parkinson's. So I think I would add that to the intensity. It's also the focus of your which muscles you're exercising and your posture. So I just want to add that.
Cameron, can I chime in on that?
Yes.
The activity that we started with breathing is actually a very powerful way to begin your exercise practice. Because the breath in itself, when you are moving the belly and the ribs and the chest, this movement begins to mobilize your internal organs, your structures. Your body is moving. So if you begin by focusing your attention on your breathing, it's going to give you a lot of information. It's going to give you information about how you're doing. Just as Kathy mentioned, you're beginning to focus your attention on this breath, and that means you stop thinking, worrying, questioning whether you're doing something right or wrong. And as you can focus your attention on maintaining a very smooth, rhythmic breathing pattern, then what's going to happen is you can encourage a greater ability to breathe in and potentially, now you still have to look at, potentially get more air in and out of your body. That could give us an opportunity for more oxygen. We're not going to say how much, but so this intensity, as Kathy's relating to, how do I know how hard I'm working? We can use the breath to determine. Just as Dr. Pepper was saying, if you can talk while you're doing it, then you're likely at a good intensity. Well, I like to talk about if you can continue breathing rhythmically and steadily when you begin an activity, an exercise. If you can inhale and exhale as you are raising your arms, and if you notice that when you're raising your arms or you're walking, you start to feel a little bit overwhelmed and you get, that's too much. And so as you begin, a gradual progression is a wonderful way to pay attention to that smooth rhythmic breath. And then from there, as you try to do a little bit more, try to do more while you can still keep smooth and rhythmic in your breathing. Just a little something.
I'd like to think of it as a little informal. Can everybody hear me?
No.
I'd like to do a little informal survey. Can I see a show of hands for those of you who chose to have the condition that brought you here today? I don't see many hands. And the fact of the matter is that we didn't choose to have Parkinson's or Huntington's or whatever. But that's not the only set of choices that we have. You've got the choice to do something about it. You've got the choice to exercise, to keep your mind in the right place and join it with your body to combat the disease. And I just wanted to throw that out, that we don't have the choice about whether or not we have to deal with this condition. But all of our choices that surround that single non-choice are still open to us. And if you're not taking the opportunity to use the resources that you have available to you, then you should spend some time thinking about why. Because, as Dr. Pepper mentioned, exercise is free, and it does so much good for you. So, thank you.
In on that one. It's interesting that for some unknown reason in our society we think that we don't have to exercise until something happens. And truly our bodies were designed for movement. This is what gets all of the circulation going, the joints lubricated, and so we were designed for this.
So I'd like to take a step back and ask Rocky to comment on initial grieving process of accepting the diagnosis, how that might relate then to anxiety, depression, and how she would approach somebody who talks to them about anxiety and depression in the setting of a chronic disease.
So you want me to talk about the initial grieving process after you first?
Yeah, because how someone works through that will affect how they accept the available interventions.
So when my clients who are first diagnosed come to me, we initially discuss a lot about who they are, right, pre-diagnosis, because they consider themselves to still be who they are pre-diagnosis, or who they were pre-diagnosis. So we talk about what kinds of things were important to them, their work, their family, what was their role within their family and society in a larger sense. And then we start to talk about their fears with the diagnosis and what this is how this is going to change their definition of themselves as the disease progresses and those kinds of things, and how this will change everybody else's roles within their family. And we talk about what to do as far as with work and those kinds of things. And we just talk about redefining life after diagnosis, who they are and what life means and what's important to them, what was important to them before and what's important to them now.
What characteristics would you say determine someone who goes through that process, grieving process, well versus someone who may not? Any distinguishing characteristics, things that they do or don't do?
Humor is huge. Having a good sense of humor is a huge protective factor. Also, not being socially isolated is a huge protective factor. That's probably the number one protective factor, is having a good social network to be able to talk about all of these things with and get help from and those kinds of things. I would say those are the number 1 and 2 protective factors.
Thank you. All right, I see Alex with a question.
Hello. I have 2 questions. One is, there's a commercial out that's really scary where the guy has hallucinations and he thinks that's what every Parkinson's patient will do, is get these hallucinations and not know what reality is. My second question is there anyone have any data, or is there any data on medical marijuana and hemp oil?
Okay, so there are 2 questions. One is hallucinations in Parkinson's disease, and the second I'll give to Dr. Yang. So the first is hallucinations. So as we said, the motor symptoms are what we're most commonly accustomed to thinking about in regards to Parkinson's disease. Tremor, slowness, balance problems, stiffness. but there are many non-motor symptoms of which hallucinations may be occurring in certain subsets of patients. So there are figures that range from 30 to 70, even higher percent of Parkinson patients who may have hallucinations as part of their non-motor symptoms. Now, this doesn't necessarily mean the same thing. So sometimes this may occur just sensing something in the periphery. Like you think somebody is there to your left, you turn, nothing's there. So that might be an early feature of what we might call hallucinations or illusions. Sometimes it is more distinct. Usually they're seeing kids, people, loved ones, animals, and they may be pleasant, so they may not bother the patient. Other times they can become more bothersome because they have suspicions or they react to them negatively. They think things are, people are in the house who shouldn't be, and they're scared by them. So there's a range of how problematic the hallucinations may be. So whenever hallucinations occur in a patient, first we have to make sure there isn't a trigger that has caused the patient who hasn't had them to have that. Usually that's another medical problem. So like a urinary tract infection, pneumonia, the flu, a fall, even if it's a minor fall, hitting the head on a fall. Or it could be a new medicine, maybe one that the neurologist started, or maybe one that another physician started. So we'll make sure that those things haven't occurred. And if they occur, then we want to treat those problems. If all of that is negative, then we may modify the drugs that the patient is receiving. Lower or get rid of a medicine. And sometimes we'll start with the least effective medicines.
Get rid of them and have the patient. I think we lost the mic.
Down here? Can you hear our way down here?
All right, so we'll lower the drug or eliminate drugs, and then if we still have problems, we will use medicines to counter those hallucinations, and Dr. Alvarez is going to go over some of those in the last part of the talk. So, and then Dr. Garcia wanted to comment.
Yeah, I just wanted to say about the hallucinations, just from a psychological perspective. One of the questions I often get is from family members, and the question is, well, what do I do when my loved one is hallucinating? And the one thing that you should not do is say, there's nothing there, I don't know what you're talking about, ignore it, it'll go away. This could only, I mean, really what it does, it just agitates the patient. They're experiencing those hallucinations. The best way to approach it, and I know it might be scary for you, but it's just to say, you know, I don't see what you're seeing, but I do believe that this is real to you and that it's happening. And also to assess whether or not this is a frightening experience to them. As Dr. Patrick said, sometimes it can be a pleasurable experience, but if it is frightening, then that's when you need to seek out help with your physician to hopefully reduce or eliminate that. But again, the best approach is just not to fight it or combat the patient, but just to provide acceptance and understanding. And in most cases, those hallucinations do pass after some time. So again, just approach it with compassion and understanding, and say, you know, I don't really see what you are seeing in front of you, but I know what's happening to you, and we'll work through this together.
There's questions from the end of the room on this other side, but the mic doesn't reach that far. Can you hear me? She wants to know the difference between apathy and depression and how you would treat them differently.
Let Dr. Yankat handle that. This is not on.
take mine.
It's a big question. Now, the science of depression is involved inflammation. That's why when you speak depression, you speak about 20% of the states, especially in the ladies. Apathy is mostly when you have the frontal lobe dysfunction, you have no initiative to do anything. It's more treatable because these people can be influenced to have more social life. This is a big question for our panel and we can discuss it forever, but I'd like to open this question about the marijuana, if you allow me. Marijuana is now every place. There is no study in Parkinson except in Israel. They study this. And in marijuana they have hundreds of alkaloids. Hundreds. We know only 2. That's why the knowledge about this is very limited, about only 2 alkaloids of hundreds. They have some success in Israel, but how much is due to placebo, how much is due to the receptors of marijuana who are in the astrocytes, we don't know. And the simple question, for this age group that we are here, above 65, is not a good decision to start anybody on marijuana because we have other options who are better than marijuana.
Tony, I think my advancer isn't working either. Technological failure. All right, so we're going to go on to the next section. We're going to still take questions. Everybody's eating, so I'll do this one. Kathy, I'm going to let you go once they're done, so that they don't have to. You're on next. Can we go to the next slide?
Yeah, hold on. That's right.
Kathy's going to. So let's just focus on why you should exercise if you have Parkinson's. I told you about everything, every reason you should exercise for general health, but there are specific data related to the benefits of Parkinson's disease, which are both short and exercise in nature. And we're going to ask the panel to comment on some of this, and we'll hear about exercising your speech muscles as well as the body, etc. So there is an immediate effect of exercise. That's increasing walking speed, having a longer stride length, and better balance. And then there are longer effects, longer-term effects, which allow to maintain balance, mobility, daily activities, associated with a better sense of well-being, as we've talked about, across all stages and severity of disease. And it also lessens your risk of falls and other complications. And so again, this is your taking out insurance on your wellness to counter future sicknesses and other traumas that inevitably occur in our lives. And so you need to consider that as part of your strategy in addressing your long-term care. So again, thinking of the art of developing an insurance of fitness to counteract sickness in the future. So why should you exercise if you have Parkinson's disease? Well, patients who exercise 2.5 hours, again, so 150 minutes per week, showed a slower decline in their quality of life. And the sooner that they began the exercise after diagnosis, the better. And as we heard from Jennifer earlier in the day, there have been studies in animal models of Parkinson's disease that exercised and showed that the brain uses dopamine more efficiently in those animals that exercised who had an animal model of Parkinson's disease versus those who did not. And remember when we talked about the dopamine transporter and that dopamine cell, there was less transportation of the dopamine back into that cell. So the dopamine stays around longer in order to work on that cell that it works on. And there were more places for the dopamine to bind, to do its job. This has also been seen in human studies of patients with Parkinson's, so not only animals. So it makes the dopamine more efficient in its work. So these places for dopamine to bind are reduced in obesity. We're going to talk about diet in the future, but it's important to recognize, well, you may exercise and you have a more efficient dopamine. As obesity levels increase, these places for the dopamine to do its job reduce. And so the ability for the dopamine to work is reduced. So for those of you in the clinic that hear from Dr. Alvarez, Dr. Yankov and I, of why we need to have wellness with diet and exercise and get to a level of body weight, it's because of these known effects of exercise and appropriate diet. It's not just theoretical. So there also was a recent study done in Sweden of 43,000 individuals. So this is related to all of you who are here who have a family member with Parkinson's disease. So this is why you should exercise if you're related to someone with Parkinson's disease. So in this study of 43,000 individuals for 13 years, the risk of developing Parkinson's disease was cut in half in those who exercise. And it's important to recognize that the benefit didn't come through leisure time or occupational activities. It was exercise that we've talked about. So not people who had leisure activity or occupational exercise, if you will. So a strong reason as to why we should exercise if we're related to a person with Parkinson's. In support of this human study, animal models of Parkinson's disease showed that 3 months of daily sustained exercise, and I believe this is what Jennifer was commenting on. These animals that had 3 months of daily sustained exercise were completely protected against the occurrence of developing Parkinson's when a toxin was given to them that produces Parkinsonism in that animal model. So it was protective as well as affecting animals that already had it of how those animals do over time. So strong evidence. Where is that evidence for marijuana or glutathione or other things you're interested in? It's right here for exercise, okay? So you need to take heed of it. It's not just thought. And so we want to start prescribing fitness activities appropriate for you as determined by the therapist group and your physicians. I want you to see exercise as the foundation. How many of you would build a house when the foundation hasn't been laid yet? Well, you're going to put up the walls and the roof without a foundation? Of course not. So you're not going to initiate other treatments until the foundation is set, and that is exercise and diet. On top of that, when necessary, we're going to add oral medications or medications through the vein or other avenues that we have available to us. And then on top of that, you might consider surgical interventions. And so always set the foundation so that all the other treatments can be most effective and affect how you do over life. So, I'm going to stop there and go back to the questions. And Kathy, maybe now we'll do your
So I wanted, those of you who have seen in the clinic, we've probably gone over this, but I wanted to talk a little bit about freezing with Parkinson's. It's, I guess not directly related to the topic today, but it's just so common. I thought it would be a good opportunity to go over
Kathy, louder.
Now can you hear me?
Yes, you usually have a big mouth. I can hear you better.
Okay. So I want to go over the topic of freezing with Parkinson's. It's very common, not everyone experiences it. I find it to be one of the more difficult symptoms to treat. So there's a pretty effective technique, but again, it requires some focus. Yes, thank you. So it requires some focus. We try to talk about this repeatedly in therapy to patients or to persons with Parkinson's and their caregivers. So you can utilize it when you have an episode of freezing. I'm of the opinion that even when you get into the shuffling gait and you have trouble decelerating that, in my opinion, it's a form of freezing. Even though you're not stuck. But this technique works very well for that. So if those of you who aren't eating, if you can stand, please stand. If you're not able to stand, if you're still eating, you can stay seated. You can do this either way. So there's a therapist in Austin named Sarah King, and she has a website called, I think her clinic is called Invigorate PT as well, but she has a website called Invigorate PT. And this is the 5 S's for anti-freezing. So the first thing, it sounds sort of ironic, because if you're frozen, the first S is you're going to stop. So I tell my patients, when you freeze, anxiety tends to build up very quickly. As a matter of fact, my patients over the years who've been the worst freezers have also been people who are very anxious. So the first thing you do is just stop. If you're shuffling, if you're stuck during turn, just stop. Okay, you need to correct your postures, or sitting or standing. You're going to sit or stand up very straight. Okay, so you need, a lot of times, if you're using a walker, it's out in front of you. You may be bent forward. It's getting away from you. You're getting into the quick steps. Immediately stop. The first S. Stand erect, or sit erect if you're having trouble doing something when you're sitting. Okay, that's the second S. The third S is shake it off, or as I say, take a deep breath. You've got to get rid of that anxiety. Think of Nydia's breathing exercise. You've got to release that tension and get rid of that anxiety in order to get through that freezing episode. The fourth S is to shift your weight. I call it a brain exercise. You're shifting your weight from your right to your left foot, or if you're seated and you're having trouble getting out of the chair, just sit back, shift your weight from one buttock to the other buttock, back and forth, left and right, okay? That's your fourth S. And then, if you're standing, the fifth S is a big step. You want to step, raise the knee high, take a big step to get started. If you're sitting, the fifth S is to stand up if you're having trouble getting up, if that's your goal. So it's stop, stand up, straight, shake it off, take in a deep breath, shift your weight, left and right, and then step big or stand up big. So those 5 things, that's what I have found to be most effective. There's different, you can even do parts of that, but I think the big take home for me is that really try to get rid of that anxiety and just don't try to fight. You can't fight freezing. If you're in that shuffling step and that walker's getting away from you, there's no way you can correct it without stopping. I've never seen anybody go that you just have to stop and start again. Some of my patients, persons with Parkinson's, will have to stop repeatedly during just a 100-foot walk. But you correct it every time, and then it will start happening less often. So, okay, that's all I can
If I may add a simple technique to your freezing. And what is freezing? Only the feet is smooth on the ground. And if you keep on going without stopping, you can fall, right? So just a simple stop, bend your knee, and then go. That also works. Also, as far as freezing, I just want to let you know, why do you freeze? When you have a stressful situation like the elevator, or a crowd, or small spaces. So those are sometimes the reasons why Parkinson's patients freeze. Thank you.
So we've focused on exercising the body, talked a little bit about the mind, but I'd like to hear from Jenna about exercising the vocal muscles, because of all of the aspects of Parkinson's disease, exercise is the only